Good morning, everybody, and welcome to another PRAXIS webinar in our series that we've been running now since March, since we had a change in practice in relation to COVID. So we'll just wait a couple of moments whilst we get everybody joined. We've got a fabulous panel, a very large panel joining us today. And we have some special guests. We have Maya from the US, founder and CEO of Find Me Cure and Trial Hub, and she'll be talking to us about their experience in the US. And we're also very fortunate to have a patient who's been a participant on a tele trial, who's going to share their experience with us today. So we're thrilled to have you all and thrilled to have all of our panelists, and thank everybody for their time. So because we do have quite a lot to get through, as always, we might head off. So as always, PRAXIS respectfully acknowledges Australia's First Peoples, the custodians of the lands that we gather and work on today across this country from wherever you're joining us. And we respect their connections to land, seas and culture. And we give our thanks to their elders past, present and future. So just a little bit of housekeeping. This is a webinar format, so you're all probably very familiar with how the webinar format works in Zoom, but it does mean that your cameras are off and your microphones are mute. There is a chat function and a Q&A function. If you could please post your questions in the Q&A if you have access to the Q&A. That just helps with the curation of the questions. But we do recognise that depending on your device, it may not be possible, and then we encourage you to use the chat function. We do, if you're sitting in a room with others and you're getting feedback, it may be because someone's got their mobile phone connection. So we encourage you to use just one connection, not a mobile phone, and a PC connection. And we also have a feedback form that is in the form of a QR code. So to use this, and we will show this at the end of the session as well, all you need to do is hold your smartphone up to the QR code with your camera on, and it should take you directly to the survey link. So we do really appreciate your feedback. We take it all very seriously and always strive to improve what we do. And as I mentioned, we will show this again at the end of the session. So today's discussion is around decentralized trials and making them business as usual. And there has been some fabulous discussions around this topic over recent weeks and certainly over recent months. And we've seen some of those discussions with ARCS and APPA just over the last 7 days. But it is important to keep this discussion going. This is such a pivotal time for the Australian clinical trials environment. And we've had some great success with MRFF grant rounds through Queensland and New South Wales, and also through regional Australia, which is fantastic news and means that we've now got some committed funding to make decentralised trials business as usual, as it says on the slide. But just a quick disclaimer. So this webinar and this discussion today is really just to provide a forum for discussion of emerging issues, and doesn't necessarily always reflect the panelists' views or their organisations, and similarly might not always reflect the views of PRAXIS. But if you've ever got any questions, we always recommend that you consult with your sponsor representative, your regulatory bodies, your jurisdictional officers, for advice at any time. Okay, so we thought we might start with some definitions, because, and it is really hard to put some clear definitions around what these various decentralised trial models look like. And I think the sector broadly, internationally, has agreed that it is sometimes hard to pinpoint what these look like. But so we're going to look at 4 different aspects, and some of them will come up in the discussion, but this is really just about providing a bit of a knowledge base around what some of these things mean. So teletrials are trials that, and in Australia, this has been the model that has progressed the most significantly, led by the work of COSA and also Queensland Health. And what teletrials do is allow a clinician at a larger centre, a more established clinical trial site or a primary site, to enrol, consent and treat patients on clinical trials in partnership with other smaller regional sites where they may not actually have an established site network. So it's a way of making sure that patients across Australia get access to trials without necessarily having very robust and established clinical trial facilities in place, because the primary site takes the responsibility for managing and overseeing the quality and the safety of participants at those other regional sites. Decentralised trials are trials that are executed through technologies like telemedicine and mobile and local healthcare providers. And it uses procedures that are different from our traditional clinical trial models. And really it's about taking trials to patients and conducting them remotely where we can. And so decentralised trials really is an umbrella term that we can use to describe all of the things that we're discussing and all of the things that you can see here on the screen today. But then when we come to virtual trials, it's important to note that by true definition, a virtual trial is one where there are no physical sites and no face-to-face interactions with patients. So all of the trial conduct is conducted by the patients at their homes where they live using different technologies. So that's the extreme model, and there have been some examples globally of virtual trials that have been very successful in recruiting large numbers of trial participants to much less complex studies. And there are certainly some benefits of the virtual trial model, but truly virtual trials is probably something that may not ever really be embraced here in Australia, but certainly elements of it can help us to have a more robust decentralised trial model. And then there's hybrid, which is essentially a combination of all of these things. So using things like telemedicine, using things like ePros, using things like remote safety monitoring and remote monitoring by our sponsors. And this is probably the ideal model that we should be striving for in Australia, where we're taking the best of all of these technology platforms and really making sure that the patient-centric approach is what we are aspiring to when we are designing and conducting trials. So what we wanted to do in today's session was bring together some of Australia's providers who are really disrupting the way that we have practiced clinical trials, who have developed techniques and tools and have implemented strategies to really take these decentralised trials to our patients, because there are some great examples here in Australia, and it became aware to us that many of the sector aren't even aware of what service providers there are. And hopefully by today's discussion, you'll get a better understanding of what's available, and you can reach out to some of the people who are on our call. So now I'd like to start by introducing our special guest, Maya. So Maya is the CEO and founder of Find Me Cure and Trial Hub. She's a digital health entrepreneur and clinical research professional with more than 10 years of experience in clinical trial regulations and training, patient engagement, feasibility, and patient recruitment. As I mentioned, she's the CEO and co-founder of Find Me Cure, and Maya's going to talk to us a little bit more about Find Me Cure and Trial Hub. And she's also an active advocate for decentralised clinical trials and sharing data among clinical research stakeholders. So Maya, I'm just going to stop sharing my screen now so that you and I can have a little bit of a conversation. And
hi, Melanie.
There you are, Maya. Hello, how are you?
Hi, so, hello everyone.
Maya, again, look, we are thrilled that you could join us today, and it really is fabulous to have you here telling us a bit more about your work. So can you give us a little bit of an introduction to Find Me Cure and Trial Hub, and tell us how it has enabled decentralised trials in the US?
Yeah, sure. Thanks, Melanie, once again for the invitation, and I'm really glad to be among this amazing group of experts. So Find Me Cure started, I started Find Me Cure maybe like almost 5 years ago, together with my co-founders, software engineers. One of them actually has built the Australian Clinical Trial Register. So I was like really like happy to be close to these people. And when we first started Find Me Cure, it was more like a project. We wanted to actually bring better awareness among patients when it comes to clinical trials. We thought that clinical trials are an alternative. We still think it's an alternative of your treatment, and we just felt that people don't know enough about clinical trials, and it's super hard to identify a clinical trial that's relevant for you, for your like closed ones, etc. And actually, we also felt that if we are to bring better awareness among people, we would also support the industry by also encouraging more patient recruitment. We just felt that patient recruitment is really like the bottleneck of the industry and still is. And so we felt, okay, well, if we bring more awareness, then maybe we'll also fix patient recruitment. But that didn't really, like, we didn't actually see that coming. We just felt that like the more we're educating patients, the more we were realizing that patients are not like that happy with the protocols of the clinical trials, or let's say there was misfits between locations where the people are and where the clinical trials happen. And so maybe like 2 years ago, we decided that like just bringing awareness won't do the job. We need to do something else. We need to actually encourage a different module in the clinical research space. And so back then I was already starting working towards decentralized clinical trials, but our expertise was more towards data science, more, let's say, connection with patients. And so we felt that we can use all this know-how, our connection with patients, these patient insights, but also connection with sites, and also the data, the clinical trial registries. As I said, my co-founders are coming from this background, and we created Trial Hub. And Trial Hub is like a platform providing you with 360 degrees overview of the clinical research landscape. And when COVID like started, it was like the great opportunity for us to actually build the first database of virtual clinical trials embedded onto Trial Hub.
So how many sites do you have currently that are virtual clinical trials ready, that are registered in Trial Hub?
So we have in total like 500,000 different sites like on Trial Hub. And I will like quickly demonstrate how it looks, but basically very much depends on the indication. And I can't say that there are really sites like really ready to do the centralized clinical trials. And also it depends on how you define that. So I would say that some sites are better prepared when it comes to using more like electronic sources and let's say CDMSs and stuff like that. But I can't say that there is any site that is fully equipped for going and performing the centralized clinical trials, especially if you define that as a trial that you can also do with your own physician. So definitions vary quite a lot. So
So what Trial Hub does then is enable sponsors to be able to find sites that have skill sets that enable them to be able to be more proficient at rolling out decentralized trials. Is that so? It's not the vision is that it will list sites that are decentralized trial ready, but at the moment it's about building that knowledge base so that sponsors can say, right, this is an important design element of our study and we need to find sites that have this capability.
Yeah, so yes and no. In the ideal scenario, you have sites that are fully equipped and prepared, but we all know that this will come with the time. The more we learn, the more we work towards the centralized clinical trials, the more prepared sites and investigators we're going to have. But that doesn't mean that there aren't like investigators and sites already like opening to or being open to work with virtual decentralized clinical trials. So what we did was like a different approach. We said, okay, let's see what defines a virtual or decentralized clinical trials. These are the different components. So there are 4 different categories of virtual clinical trial components: mobile technologies, e-consent, e-pros, and wearables. So what we decided is let's by having these 4 categories, let's now go out and see who has experience with these, maybe one of these categories, maybe two, maybe across the board, and let's like connect the database of virtual clinical trial components to the sites and investigators. So for example, if you want to go and do a clinical trial in breast cancer, for example, and you want to include a specific wearable to measure a specific endpoint, you would know, okay, that's the investigator who already has an experience.
Okay, great. So it's a way of sponsors being able to identify sites, but also patients being able to identify sites where they can get involved in clinical trials that have some of these technologies that will make their participation easier.
Yes, so that's another actually a really big topic, patients, because I remember 2 years ago I was a part of the Global Patients Summit, and only patients and patient advocates, patient organizations. And back then they were already discussing this like virtual approach and like remote, being remotely part of a clinical trial. And I remember the patients being very much confused because they felt that they want to have the flexibility. Imagine patients with all sorts of indications, and some of them feeling really afraid that they were going to be completely like virtual, or let's say completely away from their doctors. So what we need to embrace here as an industry is that like we need to provide convenience to patients. We need to provide accessibility. What this means maybe varies between the different protocols and the different indications.
So, and Roberta's just asked a question. Are there any Australian sites that are listed? And just to give you a bit of background, Maya, so we have some platforms here in Australia. One is called ClinTrial Refer. That is a way for patients and also investigators to be able to find trials. But, you know, to be able to expand those sorts of platforms to do what Trial Hub does, or perhaps for them to link into Trial Hub, would be a real advantage for Australia. So are there any Australian sites currently listed on Trial Hub?
Yes, actually there are many, and I was like going to demonstrate how this actually looks like.
Yeah, great.
And the thing is that like the way we actually work with the sites is directly and indirectly. So we would work directly with the site management organizations and the sites to gather information, but we would also enrich this information with all sorts of other data sources, primarily working with the clinical trial registries, because that's our like expertise.
Sure.
And so we were happy to partner with any of the, like even the local institutions that are even closely working with the sites to enrich these profiles and like provide better, let's say, visibility on what's happening. And the beauty about this approach is that you not only enrich with like local insights with really in-depth details, but you also bring real-time analysis. The more clinical trials with virtual clinical trial components there are, the more investigators prepared for like working on them as well, and on our platform as well.
So there's a real opportunity for Australia, you know, and one of the things that I think as a sector we've addressed is that we need to be sure that we are more internationalized and more international focused. So there is an opportunity then for us to link into to these sorts of networks and build our capability and our visibility, I guess.
Yes,
so Maya,
absolutely.
please do share your
so just give me 1 second to share my screen. And I already, so just maybe to give you a bit of an idea what Trial Hub actually does. It works with, so this is like maybe the best representation of how Trial Hub looks like. Basically, it's a mix between two main things. One is data sources, all sorts of data sources that are out there, primarily clinical trial registries. So we work with 17 different clinical trial registries, including the Australian one. And then we mix this data with local experts' insights to provide this 360-degree overview, like I said. And it's all about feasibility and patient recruitment assessment. Going through like from patients, information about patients, timelines, trial sites, everything basically, like all sorts of information about that, putting it together onto Trial Hub. And let me just now So I need to again share another screen. Okay. So you should be able to see Trial Hub now. I've already started with an indication diabetes. Trial Hub works with all indications out there. So depending on the protocol that you're working on, you can see different information. And then it covers 70 countries. So it's like a global platform. And how does it work? So at the moment, I started a project for diabetes, for example. And I want to focus now on the virtual clinical trials that are being run in diabetes. And actually, I selected already just the United States, Australia, and Germany, because I wanted to show you a comparison between what happens in Australia, let's say Germany as the like top chosen country in Europe, and then the States. So these are like 4,000, almost 5,000 clinical trials being done like historically in diabetes in Australia, Germany, and the States. And so when I go now here, and I want to just see the virtual clinical trials, as I said, there are 4 different categories. So I can choose only one category or all of them. For the sake of demonstration, I will just choose all of them. The moment I choose that, this is the moment that I filter out only the virtual clinical trials. And when I say virtual clinical trials, like I really want to understand these are most of them hybrid clinical trials that are using virtual clinical trial components and like the traditional model. And it takes a little bit time because it's real time and I'm demonstrating like live how this works. So there are 598 results. So all out of these 5,000 that we've traditionally done in diabetes, and diabetes is something that we've researched quite a lot, there are just like 598. But that's, I'm saying just, but that's actually quite a lot as well, because people think that these virtual clinical trials started this year with COVID. That's not true,
no,
actually.
Very.
We started like, and let me show you something really quickly. First of all, so these are different clinical trials. Obviously, you can filter out by status, like type of treatment, and so on and so forth. I'm not going to go into details. I want to demonstrate something else. So here you can see the different virtual components that are being used in each of these clinical trials here. But what I want to demonstrate is something else. So let's have a look at Germany. So Germany has, out of these 500, Germany is involved in 54. Not that bad, right? Australia 27. So it's like double less than Germany. And look at the United States, 466. And like if we go, let's say, if we go and just say, I want to see for the last year, because actually last year is where the whole dynamic started. So let's have a look at the clinical trials being run in the last year. Again, it might take a minute or so. Then you see that the number is actually pretty much growing, like exponentially, of the number of clinical trials with virtual clinical trial components being done. But then you see also difference between how much is being done in the States, Australia, and Germany. And that speed actually, sorry, need to refresh. And everything that happens live, you know,
yes,
it happens all the time. But so what we've discovered, I actually have the numbers here. Yeah, so 221 out of these 500 that we started with, 200 actually happened in the last 1 year. So actually pretty good. And then again, let's see. So the United States, 166, and Australia.
So there's
40.
certainly, and you know, it would be interesting to do a comparison against how much, you know, if we could do a linear comparison against how much that has changed over the last 12 months. But
yes, of course.
Maya, that's fantastic. And I guess what we wanted to do today was really to showcase that there is work being done to be able to really identify where the capabilities are, and that Australia can be part of these technologies that can, as I said, bring visibility to us, to international sponsors about local capabilities. And as our local capabilities grow, those numbers will only increase. And that's certainly what we are looking to address here in Australia. So
just one last thing I wanted to point
sure.
out here is like, this is the map of sites that have experience in diabetes and virtual clinical trial components. And you can see here Australia. And like, these are the ones with already experience. If I remove the filter for virtual clinical trials, you see that like actually it's doing pretty good. Like, most of the sites have started being involved in virtual clinical trial components of some sort. And if we start digging, we can also see what, like, you can see these are all of them. And then like, if I add again, so 6,000 are all the sites. And then the one that have experience, I think there were like 600 like in total in all of these countries. But yes, it's definitely picking up. And definitely more and more sites getting involved. And it's interesting, of course, if we had more time, to also see some the dynamic between the sorts of virtual clinical trial components being adopted. And I already had a look, and it's basically e-consent is definitely the one that's like gaining more traction, but also like wearables to allow patients being monitored in the peace of their homes.
Great. Look, Maya, that's fantastic. And again, thank you very much for being with us today. And we hope that you'll stay and be part of the conversation as we get into some of the more, some of the other questions. But now I'd like to introduce Natalia. Hello, Natalia. You can take yourself off mute. And my, I've got a lot of sunlight in the background here. Hello, Natalia. Very good to see you again. So, Natalia, as I said, wonderful to have you here, and you certainly have had your own personal experience with being involved in a tele trial. And what we were hoping that you might do today is to share what that experience was like, and to share a little bit of your story. So if you're happy to do that, we'd love to hear.
Okay, yeah, thank you. So my story, cancer story, started back in 2015. And I was diagnosed with cervical cancer at the time, and had the chemotherapy, unfortunately, it hasn't seen cancer return. And at that time, it was diagnosed as terminal, and explored options of going on a trial then, but there was nothing available. So back on chemotherapy for about a year, and then had surgery in 2017. And unfortunately, the cancer still there. And so last year, we looked at, well, my oncologist here in Tasmania, because I'm based in Tasmania, looked for a trial, and I was very lucky to be able to go on a trial, oncology trial at the Alfred Hospital in Melbourne, and that involved travelling to Melbourne every 3 weeks, and I was very lucky, and I had good results to begin with, and it was all going really well. And then coronavirus came along, and so that quickly put a stop to the trial, because it became too risky for me to travel to Melbourne, and also Tasmania closed its borders. So the trial was halted, and it was really unknown as to whether I'd be able to continue and when, but I was very lucky to have an amazing and hardworking treating team at the Alfred who were willing to look at the option of getting the trial happening down here in Tasmania. And I'm aware that they'd never dealt with anything like that before, and that it was a really involved process and involved a lot of people, but they succeeded. And in May, I was able to start up on my treatment again down here in Hobart. So that's been amazing.
So Natalia, tell me then, if the team that supported you obviously went above and beyond to make this possible for you, but what would have been the outcome, do you think, if you couldn't have continued in the trial? And what did the teletrial experience look like for you? So from a practical point of view, what did it actually mean?
From a practical point of view, I guess it meant that firstly I was able to continue on the trial, so that was the biggest, most significant outcome. And so for me, I guess that means that I'm still here. I'm very lucky. Every day is a blessing. And it means that I travel to Hobart instead of to Melbourne, which is less financial cost and less time away from home as well, which is quite important for me as I'm a single mum with children. So it's just made the whole process easier and possible. Yeah.
And Natalia, did it change your appreciation for clinical trials as well? Because did it become much less burdensome because all of a sudden it meant that it wasn't such an imposition on your life? It just became part of your routine care?
I guess, yes, if I look at it that way, definitely. But I guess at the time, to be able to have any trial was a amazing thing. But if I look at it in a practical sense, definitely what you said means it has less of an impact on my daily life and my family life with planning trips. Like it was quite involved to plan flights and hotel accommodation and things when I was going to Melbourne, whereas now it's a drive down to Hobart and I can do it in a day, which is great.
So what would you say to the Australian clinical trial sector, and we've got several hundred of them here on the conversation today, about what this has meant to you? So what would be your final comment to them?
I guess for me, it has meant everything. It really has meant that I'm still here for my children. So if anyone can do anything to make it happen for patients that need the treatment, do everything that you can. I'm hugely grateful, and I'm sure anyone else in my position would be too.
Oh, Natalia, thank you so much again for sharing that story. And I think it's just so important for everyone to hear the voice of the patient and the participant and to understand what this means in a really pragmatic and practical sense, because, we're all at one end of the discussion, but you're the reason why we do clinical trials, and to hear from you how much this has changed your life and made such a positive impact is exactly what we all need to hear, and hear over and over and over and over and over again. So thank you very much. And Natalia, we really want you to be part of this discussion today as we open up to the panel. So now we are going to open to the panel, and I can see there are questions coming in, but bear with me while we... So just making sure everyone can see my screen again. And our panelists, you can come off of mute in a moment. Okay, so let me introduce you to the rest of our panel. So you've met Maya and Natalia. We've also got Trina O'Donnell, who's the operations manager from Belbury. So we're going to hear a bit about some of the ethical aspects of decentralised trials in Australia. We've got Rima Darwish, who is the Director of Central Pharmacy Logistics Australia. And one of the biggest barriers we've heard has been about getting clinical trial drugs direct to patients. And Rima's going to talk about how they have made this possible and overcome some of the regulatory hurdles. We've got Roberta Lusa from Queensland Health, who's been very instrumental in rolling out the teletrials model that has very much been driven by Queensland Health, and we're entirely grateful to them for their work. Sandrian Luaz from Advanced Clinical, and Advanced Clinical is one of Australia's CRO success stories, and they have rolled out a model for promoting and supporting decentralised trials, so we're going to hear a little bit more about that. Tina Thorpe from Illingworth Research with the mobile nursing resources that they offer, and how that really promotes patients being able to conduct their trials from home, so that real patient-centric approach to clinical research. Medea Servery, who is an independent specialist who was very much involved with the rolling out of teletrials across Orange and some of the other districts in rural New South Wales. Cheryl Ann Hawkins from Oncology, Alfred Health, who have been, was one of the units that supported Natalia in being able to access teletrials, and she'll talk about the work that they're doing. And Ramya Ramchandran from Bristol Myers Squibb, who also have a platform for supporting decentralised clinical trials. So let's go to our first question. And Medea, this one is for you. So implementing teletrials or any form of decentralised trials is a lot of work, and I'm sure that everybody would support that. But what realistic resourcing is needed at the site to successfully implement these formats?
Well, good morning, Melanie, and thank you for the introduction and that rather interesting question. I just want to start off by saying that Natalia's story is a powerful story, and one of the reasons why, although it's a lot of work to implement teletrials, why it's so crucial and important to keep going and making sure that we push the ball ahead to make sure teletrials becomes part of the norm. So I want to start off by just saying good morning to everyone on the webinar today, and thank you to PRAXIS Australia for having me here. I'm so glad to see so many of you have joined us to be today to be part of this exciting discussion of decentralized trials, including teletrials. I'm going to be reflecting upon my experience of implementing teletrials and being one of the first people in New South Wales to have successfully obtained approval for teletrials in 2 separate New South Wales LHDs. So going back to the question, what realistic resources is needed at a site level to successfully implement teletrials or other decentralized trials, I think it's important to start at the basic level. So if you are currently an investigator, researcher, trials director, or operations manager looking at starting teletrials or other forms of decentralized trials at your site, I would like to help provide some hints and tips on what you can do to help with your journey. So to start off with, when implementing any new project such as this, I think it's important to establish with key stakeholders within your institution, such as research executives, RGO, research office, HREC, that they are conceptually on board with the idea, meaning that they have a bit of an understanding about what is teletrials, and they're happy to conceptually support looking into this to making a reality at your site. I think that's a crucial step. It sounds quite obvious, but I think it's crucial to have the support there before you start on this journey. Then I think the next crucial point is to ensure that there's a central point of contact or person who will be responsible for the day-to-day work of implementing teletrials, so such as a teletrial project manager. At the bare minimum, I would recommend sites having a 0.4 to 0.5 FTE to cover this role. I think it goes without saying, if your institution can find someone with previous experience of implementing teletrials or decentralized trials, that would be a bonus. But as I mentioned, there is a lot of work of implementing teletrials, and some of the examples of the work this person would take on and task are such as working with the site's legal team to establish an overarching agreement, memorandum of understanding or contract, so teletrials can take place between the primary site or the satellite site. So I must stress that this is very much up to the individual institution how they go about doing that. It also depends on whether you're a private institution or a public institution. Then you have to go about doing things such as establishing and implementing teletrials, such as safety and oversight committees, work groups, site-specific or contextualize the teletrials SOP readily available at the moment for things such as IMP management, EMR use, monitoring requirements, and teletrial consenting. What's also some of the tasks that the tele-trials project manager will require to do is establishing business rules for the model of tele-trials your institution chooses to implement at your site. So it must be stressed there's no standard tele-trials model per se. It's dependent on your business need and your site's availability for technology such as telehealth, which should, thanks to COVID as a silver lining, is more readily available than before. And also things like tele-trial CTR agreement and costings and much, much more other items are needed for the tele-trial project manager to do. So it's crucial to have 0.4 to 0.5 FTE. There's a lot of work. And I should also add that other important resources and requirements is that it would be beneficial if the investigator or the researcher was not only just highly motivated, most researchers are from our experience, but also that they were able to support the tele-trials project manager to act as a soundboard for when problems or issues arose, and that the project manager and the tele-trial researcher had a really good, close working relationship to ensure that the success of the project occurred. And in the ideal world, it would be great if someone from the satellite site could dedicate a couple of hours per week to help with any issues pertaining to the satellite sites, ensuring both that, that the primary and satellite site had some sort of bandwidth, so to speak, to cope with any unexpected things or eventually with high recruiting studies. So
sorry, Medea, so it sounds as though this is quite complex. There is no easy solution, but it sounds as though you really need to have a champion at the site.
Yes, absolutely.
And it has to be a dedicated resource to someone who can drive the implementation, because we do have things like the centralised SOPs that have been driven by COSA and Queensland Health, but it really is about having somebody there to operationalise this.
Absolutely. And it's stories, when researchers like myself hear stories like Natalia and our own patients, there's going to be a hard slog in getting things implemented because of just the nature of tele-trials, unfortunately, especially in this moment in time when it's not normal or standard of care. But it's definitely worth the effort. Stories like that, just hearing Natalia's story today motivated me completely and re-energized me to why this is so important and why the effort must be made.
I think you're so right, Medea, and I think we need to hear more of these stories because we're not making those stories more publicly available so that everybody can really understand from that patient-centric approach about why this is important. So again, Natalia, and there's been lots of comments in the chat thanking Natalia for sharing her story. So all right, well, we might keep moving. So Cheryl-Anne, this is a question for you. And your team was able to support Natalia in obviously accessing decentralised trials, but they were also able to mobilise really quickly to take an early study to a patient in Tasmania, which is Natalia. What were the enablers that contributed to this success? So what helped you to be able to do that so rapidly?
Thanks, Melanie, and also thanks, Natalia. So the main enabler was COVID. We would not have been able to get to the position or to the outcome. We could not have been able to achieve the outcome we could achieve if COVID hadn't have come along. And it absolutely was a silver lining to have our team mobilised so quickly. And Natalia was definitely also a huge motivator for all parties involved. I actually had received funding from COSA for a dedicated person to set up tele-trials at our site, and they were working on the project from January through to April before COVID did hit. And this person was able to access the toolkits that are available publicly, such as COSA and VCCC toolkits. So at our fingertips, we had SOPs. We had a Medicines Australia subcontract that was really important and key in regards to the RGO aspect of having this clinical trial approved rapidly as a tele trial. And we also had a very motivated sponsor. Interestingly, we tried to find other cases of using a tele trial concept to mobilise an early phase study that involved IV therapy, and we couldn't find a similar case. So we had to create our own path and find a way forward to be able to treat Natalia down in Tasmania. We knew that the potential for Natalia to travel back to the Alfred in any future months was going to be limited, and we really wanted to be able to offer her the treatment. The sponsor of the clinical trial was on board from the start, and that made a huge difference to our team and to the capabilities of our team to be able to bring the clinical trial to Natalia down in Tasmania. So we were in the fortunate position that we had a project manager, we had a motivated sponsor, and we also had a motivated medical team. So our head of unit, the PI of the clinical trial, and also the medical team down in Hobart. So we were able to engage the Royal Hobart Hospital very quickly. They weren't part of NMA, so we didn't know whether or not they would accept the ethical review of the clinical trial. So we had a lot of conversations and with the Department of Health in Tasmania, and because of the Natalia story and because of the other patients that we had in Tasmania, everyone really pulled out all stops to ensure that this clinical trial could be conducted at the Royal Hobart Hospital. I was also very fortunate that our RGO department worked on this pretty much for a week. There were a lot of people that worked probably for 4 weeks full time to try to mobilise this clinical trial, including pharmacy. So the sponsor also, we were actually in a fortunate situation because it wasn't a randomised study, it was an open label study, so we didn't have to work out how to keep the patient blinded through the tracking of the drug. So we were able to ensure that the drug was able to be sent down to Tasmania a week before dosing was due. So at the end of the day, we had a lot of people who were prepared to put in a lot of time to be able to ensure that the success of dosing Natalia in Tasmania. The other enabler we had introduced an electronic investigator site file last year, so it was relatively easy to set up the site file for Royal Hobart Hospital through SiteDocs. So it wasn't any one individual, it was a team effort, and we feel we have got a map now set out quite strongly to be able to enable clinical trials in any teletrial site. And we've implemented a few strategies for the future for other teletrial locations around Victoria.
Yeah, and I guess that was going to be my next question, Cheryl Ann. So from what you've learned, and it sounds as though what Medea had said is very much applied to your scenario, in that this is resource intensive and it takes a team of very committed people. But
Absolutely.
have you been able to expand this to allow other participants to take advantage of what you've learnt through your experience with working with Natalia? And how much easier will it be in the future because you've now done that groundwork?
Sure. What we actually had put together for Natalia's case was a map really for the future, and we actually were able to mobilise a second clinical trial relatively quickly after that first one down at Royal Hobart Hospital, and the resources that we required for that first clinical trial, we now have in place, and other clinical trials won't be as intensive to get up and running at Royal Hobart Hospital. But saying that, if we actually are engaging other sites around Victoria, and we do need to do a lot of the hard work again to have those clinical trials on site. And I'm very fortunate that I've got a project manager now to manage that process, because you do need someone who is able to coordinate the regulatory and the ethical side of a teletrial project. And you also need a really motivated sponsor. So I know many clinical trials have been completed without a sponsor. They've been collaborative or investigator-led studies. But I think we had a unique situation of having a sponsored early phase intravenous trial, and without the engagement of the sponsor and without engagement of the ethics and RGO of the teletrial sites, you know, it is a little bit of an uphill battle, and that's what we were finding prior to COVID. We couldn't get in that engagement. There was no motivation. But now we have got engagement and there is motivation, and I think that many people within the clinical trial community, and especially here at the Alfred, we've realised the importance of being able to bring the clinical trial to the patient rather than expecting the patient to travel to us at the Alfred.
Yeah, great. And again, you know, you've got Natalia as your case study that, you know, you can use to really be prompting involvement.
Absolutely.
But again, you know, resource intensive, needs a champion, and has to be contextualized, because there isn't really a drop it and play solution. It has to be contextualized to the trial and also to the site. But the more you do this, the better you will become, and the more streamlined the processes will be.
Yeah, and you actually get more efficient at doing it also. And there's a lot of resources out there. You need to review them. You need to use them. You don't need to you know, develop them yourself. They're
recreate
there.
the wheel.
It's just a matter of operationalising them.
Absolutely, and we're going to see more of that as the outcomes from the funding rounds are developed and rolled out across Australia over time. All right, Trina, a question for you around some of the ethical implications. So there are still a great number of research projects, not a great number of research projects that include teletrials or decentralised trials across all regions of Australia. I mean, Queensland is probably the exception here. But are there perceived or actual ethical barriers to including teletrials? And how did the Bellbury HREX respond to changes to trial design, including the addition of virtual or remote visits during the pandemic?
Thanks very much, Mel, and thanks for the opportunity to join in this webinar. It's great to be able to talk about the clinical, about teletrials. For us, there certainly are a number of considerations in using teletrials, but it's also really about just telling us what your plan is. And I think it's around communicating what those plans are for the ethics committees. Over the last few years, I guess since discussions began around teletrials, we thought there might have been more opportunity to take this up. And certainly we've seen with COVID that has accentuated that. And there's certainly been a number of teletrials in the oncology space, but it's interesting to, I guess, look at ways at how that can be expanded. And I am aware that there are perceptions and examples of where maybe it's the ethics committees need to understand those teletrial plans. But from our experience with the ones that we've seen, we've certainly been able to work through those. We can see the benefits, and when we're hearing today about the benefits of teletrials, you know, whether it's that increased accessibility, you know, the travel reduction, the opportunity for a greater participation, and that engagement. But we also know there are challenges, and whether that's for the sites and the participants around the costs, and as we've already heard about, you know, the resourcing that's needed to make that happen, whether that's people, whether that's infrastructure and technology. But in thinking about what's actually needed for the application, I thought I'll maybe touch on some of the considerations that are being made. I think some of these will be apparent to everybody that's here, but just to summarise them, and so these are the things that tell us your plan, what you're actually going to do, put it in an ethics application, and the committee will consider those. So for the sites, does the coordinating site have the capabilities to conduct the trial? consider what the capabilities and the capacity of the site is to do that. And that's both at the primary site, but also at those, the satellite sites that are actually going to be involved in doing the study. How do you select those sites and get them involved, and what's going to be relevant for those sites to be participating in that study? What medical support's going to be there, whether that's the people, whether that's the pharmacy, whether that's the testing that needs to be done, pathology, you know, what other additional resources are needed at those sites. Other things might be around the roles and responsibilities of the sites and making sure that it's really clear for each of those sites what their responsibility and what their piece of the puzzle in that study actually is, and outlining that in the plan as well. It might be, you know, that's going to vary from study to study, as we've talked about before, and from site to site, and making sure that that fits in with what the staff and the sites have, what their delegated responsibility is going to be, and how you're actually going to undertake each of those functions, both at the primary site or from the primary site, and at actually those other sites that are going to be involved. How those staff going to be trained in both the protocol, the procedures, what's going to happen when there's adverse events, how are they going to be managed and reported, thinking about there's documentation, how the site master file is going to be managed, thinking about the security of the information. That's obviously a really important factor with running these studies remotely. And probably one of the key questions that does come up through the reviews is about making sure that that data and the information about the participants is actually managed appropriately, and how you're going to store that, and having systems in place for doing that. And even just the documentation, so making sure that the sites that are involved and the staff that are involved have access to the relevant documentation, protocols, IBs, and all of the relevant study information. And also, sorry.
So Trina, as always, it's always about making sure that you understand what the ethics committee require to enable them to make their judgment, because the ethics committee, you know, principally are always going to support any attempt to increase accessibility for patients and to make trials more patient-centric. It's just about making sure that you understand how you articulate that in your submission.
Absolutely.
And I guess, you know, from Belbury's perspective and from other ethics committees' perspective, it's probably about having that conversation with your HREC when you're ready to put a submission in that has some of those virtual elements included, just to make sure that you can respond to the kinds of questions that you know are going to come up as part of the review process.
And we'd certainly encourage that. Having those conversations is really valuable. Talk through what your plan is with the ethics committee, and certainly from our perspective, we're always happy to help with that. And I'm sure that'd be the case across the ethics committees, to talk through, this is what we're thinking of doing, and they'll be able to provide advice on maybe where some additional information is needed. But putting all this together in the plan is what's key.
And so Trina, does it need, and you know, I'm trying to think about reducing burden. Does it need a separate element of a submission package? You know, is it a document that needs to stand alone that says which elements you're going to conduct virtually, or is it just actually including it in the normal submission process, or should we separate them?
So it doesn't really matter. It's just making sure that it's there. I mean, if it's all part of the protocol, that obviously, and part of the initial, you know, overall submission, then that obviously makes things easier. But for example, in the current times, over the last 6 months, we've literally received hundreds of amendments. So obviously in a lot of those cases, I guess we've seen both. There's been updates to the protocol, but there have been those separate submissions for applications. And that's really been one of the challenges for sponsors and sites in the number of changes that have been made, because it's for a number of sponsors, it's not just about one application or one submission for one study. It's about considering how those changes are relevant to multiple studies across multiple sites, and for sites as well, you know, from their perspective, a number of studies as well. So one of the things that we ended up talking about and bringing in was a batch type process. So the sites and the sponsors, depending on who was actually submitting those changes, could submit a single application outlining what their plan was for the COVID changes, telling us which studies and sites it was related to, and then we would apply that to each of those cases and consider it for each of those cases. But it meant that there was a single application, as opposed to, in some cases, for some sponsors, maybe tens or, you know, 100 or different applications.
So a much more streamlined process. I do note, Trina, that somebody in the Q&A channel has said, you know, an FAQ by ethics committees on what are the considerations for including virtual elements would be really helpful, and I think that's a really great suggestion.
Yeah, I think it is. Yeah, we certainly found that helpful during the last few months, that some of the FAQs that we put out, I think were very helpful. So
yeah, absolutely.
Translating that into this more broadly would be a great idea.
Yeah, I think Belby's done a great job in responding very rapidly to the changing environment. All right, now we're going to ask Sandrian from Avance to tell us a bit about some of the electronic solutions that are available through organisations like Avance in Australia to support decentralised trials, and how are sites using them, and is the uptake growing rapidly?
Thanks, Melanie. So yeah, we are a CRO, so we're working between sponsor and the sites, and we have a range of options available to find the best solution for data collection. And one of, I guess, the most known at the moment is eConsent. We've also got eSource, where sites can collect data directly into the database. They can use tablets, laptops, or any sort of device. And this can also be used by mobile nurses who visit patients directly at their homes, and it can standardize data collection across sites, which can be quite beneficial, including across countries, if we look at the broader side of the clinical trials. Some of the other options we have and used before is ePro. I guess it's one of the well-known out there, the patient-reported outcomes. So anything like dosing diary data, questionnaires, quality of life, pain scores, that's hugely improving the quality and accuracy of data. And it keeps patients more connected. They can get reminders and text messages from the sites, or from even the system messages are quite personal now, and just remind them to take their drugs, see how they're feeling, and all of their data is readily available to the sites as well as the sponsor.
So how have you seen the uptake by sites that you work with, Sandrian?
We've had a lot of interest, especially coming from the US and from other countries because of COVID. However, once they see how Australia is managing so well, the sites are still seeing patients face to face. Our monitors still go in, monitoring the data on site. So we have a number of studies where sponsors sort of pick and choose. Some of them just have the ePro, some of them just have the eConsent, but we haven't run a full virtual trial just yet. There's so many systems out there, and yeah, we work with a lot of our sponsors to see which areas could be of benefit, and the sites have been very open to using that as well.
So I guess the benefit of what you've created, Sandrian, is that it is one central resource that has a number of solutions that can be deployed to meet the demands of a sponsor or a site that's looking to bring in even just one or two elements of decentralised trials. It doesn't need to be an application of all the solutions. It can be, right, we're actually just going to use eConsent for this study because we're dipping our toe in the water. Is that correct?
Yes, that's correct. And the systems are compliant, GCP compliant, and we know who we're using. There's so many systems out there, and we're always open to exploring other ones. It's been some good discussions on here already, but to see what other sites have been using and what works for one site might not work for other sites. And especially for later phase trials, I can imagine that, these things can be very, very valuable for the studies.
So, Sandrine, it would be great if you can perhaps post a link to the solutions that you offer in the chat so that others can see them and can go directly to them and get a better understanding of what Avance is doing. Because I think, you know, as an Australian-based CRO, you're probably one of the first. There are certainly CROs like IQVIA and some of the larger global CROs that have some great solutions, but it's wonderful to see Australian-based CROs also really, you know, putting their foot in the game and providing solutions that meet the Australian context. So congratulations to Avance.
Thank you.
All right, Tina, you know that I'm a huge supporter of the mobile nursing workforce. I think, you know, it's something that the US has been doing for, you know, decades now. But so if we as a society has embraced innovations that improve productivity and time management, but in what ways have we offered clinical trial participants a better experience with reduced burden on their time? And do home visits offer greater control and convenience for patients? And I know that you've been right in there, Tina, and you've seen this and done this firsthand. So it's great to get your experience and insights.
I have. Thank you very much, Melanie, and thank you very much for inviting me. I'm really excited about this topic because, as you know, I think that, you know, it's really about embracing patient centricity. And absolutely, I think there's no question that home visits offer a reduced burden on time. Like you say, I've been doing home visits for patients, and over the last couple of years, I've been doing visits for a patient who actually lives here in Melbourne, but the site that he is enrolled at is actually in the US. So he would have had to fly back to the US once a month with, unfortunately, very little notice, probably no control over which flight he got, you know, days at a time away from his family and his friends and his support group. But because we could do the home visits here in Melbourne, it reduced the amount of time that he had to go back to the site. So he was going back, I think, once every 3 months or once every 6 months. And of course, when COVID hit, he ended up having all of his visits done over here. And I think, you know, besides that long distance flying, anyone who's ever been to a hospital for a clinic visit, even here in Australia, knows that, you know, you got to take your book, your snack, your water bottle. You got to expect to be there half a day, pay arm and a leg for parking and all of that kind of stuff. And at the end of all of that, you really only get to see your doctor or nurse for a very short period of time. Prior to working with Illingworth, I used to work in a tertiary hospital and had my clinical trial participants seen in a busy outpatients clinic. So even though I tried to get them through as a priority, it would often be like an hour or more of them waiting, and you could just see how tiring it was, you know, even thinking about, have I put enough money in the parking meter? Am I going to have to duck out? And then am I going to miss being called for my clinic appointment? You know, home visits eliminate all the stress of that, the parking, you know, the costs of getting there, the travel time. Besides all of that, you've also got the comfort of being in your own home where you can sit in your favorite chair, you can get your infusion done while you're sitting there relaxing. You've got your own personal research nurse, essentially, particularly at Illingworth. You know, we try and make sure that the same nurses will go and see the patient so that you develop that relationship with your patient. You get a better sense of their overall well-being from a nursing perspective as well. And then the site gets a more real-world picture of the patient so that our RNs all work as an extension as part of the site staff. So there's a lot of communication between us and the site.
Tina, what have been some of the regulatory burdens or some of the other burdens, and whether they're perceived or actual? So things like cost. And I know there's been a strong and a very rapid shift to mobile nursing in clinical trials, but how have you found overcoming the regulatory burdens here in Australia?
I don't think we've had too many issues at all. It's been very well accepted by, you know, sponsors and ethics committees and CROs. You know, it's very patient centric, and I think it's been taken up quite easily, which has been great.
Fantastic. So you've seen the number of trials that include mobile nursing just grow, you know, exponentially over the period of COVID.
It was growing prior to that, but probably at a slower pace. Certainly since COVID hit, it's, as everything within this kind of sphere, it's really definitely taken off and been much more willing to be engaged with.
And I guess if I reflect, Natalia, on your story, you still have to travel to into Hobart to have your visit. But imagine if the nurse could have come to you as well, how much that would have even reduced the burden on you even further.
Yes, I've been listening to Tina and thinking how amazing that would be. Yeah, yep.
And, you know, the wonderful thing is we have all of these resources, and yes, there are considerations such as cost, but, you know, we really need to be thinking about implementing and embedding some of these things into the design of our studies in more meaningful ways. All right,
Absolutely.
Roberta, over to you. So Queensland has led the charge in implementing and supporting teletrials, and congratulations to your team. But what do you see as our immediate future for rolling out teletrials across Australia, and how will it look different from today?
Hi everyone, and thanks Melanie for inviting me to speak today. Like many of the other panelists here, I'm very excited and quite driven and very committed to teletrials, having been involved in Queensland Health's charge. And I'd also like to say, Natalia, I am really happy to meet you face to face, because when Melbourne, Victoria and Hobart needed to work together to enable your continuation of treatment and participation to the clinical trial, I was contacted by Hobart Department of Health and the sponsor in Victoria, and we worked together to give them our experience of what happened in the Queensland pilot. So it's really lovely that everybody just jumped on board to make it happen for you. But yeah, I think the next step would try and be and see if you can be treated at home, if that's what you want as well. So I think teletrials is now catapulted, as again many of the other panelists have indicated, into the eyesight of everybody, from patients through to government policy makers. And COVID certainly has had a silver lining, because it's converted a lot of the naysayers. But one of the things that's come across to me this morning is, with the previous speakers, hearing how there wasn't an awareness of trial support or information for ethics committees and how to do things. It kind of hits home to me, thinking, well, they were all there in Queensland Health. So obviously we didn't do a good enough job in getting the communication out there about what we were doing, or maybe we did and it wasn't disseminated. But I think now the awareness of teletrials and how it works and what it involves is a lot more in the forefront of people's minds. The immediate future is this awareness that needs to get out there, and that's currently happening. And one of the fabulous pieces of news, Melanie, you've already alluded to, is the MRFF grant that Queensland Health, with Victoria, Tasmania, South Australia, Northern Territory and Western Australia as our co-applicants. We've been granted $75.2 million to roll out teletrials nationally. New South Wales also got a grant, and one of the components of that grant is to do exactly the same, New South Wales. So there'll be a national collaborative approach to roll out teletrials. Obviously, it will happen in various stages depending on the readiness of each of the states, but everybody is on this train from the government point of view. So it has the support and the awareness that each of the states need to start rolling this out. And what it means is that each state and territory will have what's called a regional clinical trial coordinating centre. And their purpose over the next 5 years is to scope the region for clinical trial capability and capacity, scoping the population in each region to see what trials would be what would be a good trial to take out to those regions, and ensuring that the relevant clinical trial gets to these populations using telehealth and the teletrials model. So there will be project managers, similar to what Cheryl-Anne was saying in the Alfred or perhaps in BMS, that they will be doing all of this work with a dedicated team, upskilling the regional areas and the staff, promoting the teletrials model and making this awareness spread to their local communities. So there was many questions and comments raised in the earlier questions that I think could be answered by the teletrials SOPs, and that they are in the process of being ratified by the Clinical Trial Project Reference Group, CTPRG, because I reviewed the final documents yesterday. So very soon they will be rolled out, and we hope that everybody will adopt them. I think there is an expectation that they will be adopted. Queensland Health is also working on guidance documents which will indicate how you could assess which trials could be teletrial doable, because I think we have to admit that not all trials will lend themselves to the teletrial model, but everybody should be looking at making as many as possible a teletrial. And if there are, I don't want to call them barriers or hurdles, but if there are obstacles, then we need to all work as a team to find out how we can jump over those obstacles and make it, or flatten obstacles and go over it. So the guidance document will also delineate responsibilities from the sponsor, the primary site, the satellite site, the ethics committees and the RGOs, what needs to happen, right down to appendices that give a step-by-step guidance of what documentation should be supplied to the ethics committees or to the RGOs, how the RGOs would review this on ERM for Queensland and for Victoria, and lots of those little steps that will hopefully take away a lot of the unknown in the comment that we heard before. So I think when these documents become available, then this should clarify a lot of the vagaries that are around teletrials. And just want to pick up a point that Media you mentioned before, that, and Cheryl-Anne, that it takes a lot of resource. Yes, it does, but with it becoming business as usual, it will just happen like second nature and automatic. Everyone will go into automatic mode. And I like to refer back to when Australia brought in the single point of ethics. I can't remember how many years it took, and all the negativity that was going towards that it'll never work. And yet look at us now. It's business as usual, and it has been easy, and it doesn't take any extra work. And probably I would suggest that there's less work involved in single ethics review, with the majority of the work being done by the lead site. But, you know, all our other public health institutions and a couple of private ones accept that one single review. So I really think that the future is, it will become business as usual, and it will be a hell of a lot easier.
Wonderful.
And
so Roberta, I think we could all agree the future does look bright. I think it's important to recognise that there are challenges, and I think Cheryl-Anne and Medea really honed in on that fact about resourcing and challenging and resources and local advocates, because that's really something that we need to think about when we're looking at the funding model for clinical trials in Australia.
Yeah, can I just make 3 quick points?
Oh, we've got to keep moving. We're running out of time.
Okay, well, just that the subcontract is going through NMA, Medicines Australia.
Yep, great.
Yeah, and more than a year ago, there were at least 20 teletrials already happening, and most of them are CRG, being done with the VCCC and COSA. And there was a very interesting slide at the ARCS conference where it was pointed out in 2017, 85% of the global population had access to internet and a medical device. Thank you.
Thank you, Roberta. That's great. All right, Rima. This, to me, is one of the most important parts of the discussion. So when we first started running these sessions earlier on in the year, and we were talking about disruptions and adaptations, you're still on mute, Rima, if you want to take yourself off. There's a little mic icon, and you just need to unclick it. But one of the biggest challenges was actually getting drug to site. And what Central Pharmacy Logistics and Rima's company have done is actually make that a reality by managing clinical trial drug logistics, and particularly in getting drugs to patients to enable virtual trials to be a reality. So we'll just see if Rima can come on board. If not, Rima, we'll go to the next question while you work out how to unmute yourself.
I think you
Hey, you got it. Well done.
Sorry.
You got it.
My computer froze. I'm so sorry. Okay, so I'll just quickly explain. First of all, it feels like, you know, like we're talking about tele-trials and we're talking about, you know, making things more patient-centric, home nursing. Everything is there to make it more patient-centric. And when a trial involves an investigational product, I feel like CPL or Central Pharmacy Logistics is the missing piece of the overall solution. So what Central Pharmacy Logistics are, and I'll refer to them as a central depot because that's the American term used usually for this type of service, is so we are licensed by the Pharmacy Authority in Australia to provide a clinical, an investigational product, regardless of where that patient is, whether they're remote, regional, so in Tasmania, for example, as Natalie is from, or the Pilbara region. So we're licensed to do that. Now we have the depot that we have is attached to the pharmacy. So the depot is GMP TGA licensed, and when we get a request for the investigational product to be sent out to the participant, it's basically sent to the pharmacy and we can dispense that, and we get premium couriers to do it. We do it all within the legal framework, of course, so that sponsors, clients, patients don't have to worry about all that. So it's done all within, you know, it's registered pharmacists. So CPL is Australian owned by pharmacists. The shareholders are all pharmacists, and that's why we're able to do that. Now, we also use premium couriers who observe the Privacy Act. And therefore, your investigational product is looked after with temperature control and reaches the patient's door. So it's basically a door-to-door service, all within GCP, federal and state laws being observed.
So how have you found navigating the regulatory frameworks and regulatory system here in Australia? So from an ethics perspective, but also from a TGA perspective?
Yeah, so basically the TGA does not, as long as the product is, the investigational product is in a facility that is TGA licensed, the TGA has no issues with that. Now, as far as the Pharmacy Authority, as long as the product is dispensed by a registered Australian pharmacist and dispensed using the correct dispensing programs, all the privacy is and confidentiality and security is observed. And then of course, the patient is counselled, which is all part of the process. And there are SOPs as well set up for this. Okay. Then there should be no issues at all. Now, as far as HREC is concerned, it's up to the sponsors, the clients, to put it in their protocols, that this is what they want to do. Even for nurses to go out to the homes, that has to be put into the protocol. If there's no specifics in the protocol regarding the IP, then this can be done. And it is being done at the moment because of COVID. We're trying to stop patients coming in to hospitals. We're trying to keep them out. So this was always coming. The demand for direct-to-patient provision of investigational product has been happening before COVID. It was 24% of clinical trials were doing this anyway. But since COVID, the demand is apparently, I've been told, shipping direct to patients in the US has gone up by 500%.
Yeah, Maya, I don't know whether you want to reflect on that. Has that been the experience that you've learned about through Trial Hub? Is that one of the metrics that's measured in Trial Hub, is their ability to do direct-to-patient IP delivery?
Yes, exactly. One of the things that we also assess when looking at a landscape, clinical resource landscape, is like how can you actually go direct to patient? And there are different layers, but one of that is like distributing the drugs and like whatever wearables or whatever is actually needed.
Great. So Rima, you're then working collaboratively with international sponsors that are conducting their trials here in Australia, but also with CROs and agencies like Illingworth?
Correct. So if a sponsor doesn't have a nursing already organised, then we're working in partnership with Illingworth. And what a perfect partnership to have. The investigational product arrives at the same time as the nurse does. So the nurse can do the IV infusion, the nurse can do that subcutaneous injection, collect the blood.
And the accountability data as well.
And accountability. So working with GCP nurses is such a bonus, such a great thing to have. So I really feel like it's just the perfect support for decentralizing clinical trials, making it accessible to all the patients, making it patient-centric, and adherence for a patient on a clinical trial, which is so important. And it's so important for that sponsor to have that data at the end of the day.
But just to reiterate, Rima, it can work without partnerships with organisations like Illingworth as well. It can be just a relationship with the sponsor and depending on the nature of the trial. So there are solutions for every problem effectively.
Absolutely. It can work with tele trials. I know tele trials are using satellite sites for their pharmacy, but I mean, not every patient can access those satellite pharmacies. So this can work really, really well with tele trials. It can work well with anything. And I know that patients still need to see their doctor and they still need to see, go on site, but it reduces the number of trips and waiting and the costs for that patient and convenience.
And I was just in a regional area of South Australia recently where their one pharmacy was shutting down. So that meant really that anybody within that town or in that region would need to travel significantly to get access to just their standard medications, but also if they were on a clinical trial and they were getting direct to pharmacy. Whereas this can come in and really solve some of those problems in regional Australia where we're seeing businesses like pharmacies closing down because of the broader impacts. But let's continue on, and thank you to all the panelists. You're answering the questions in the chat and in the Q&A and doing an amazing job. Thank you so much. Ramya, if you'd like to pop your video on, and we'd like to hear a bit about how pharma and industry have responded, and particularly from the perspective of Bristol Myers Squibb.
Thanks, Melanie, for having me here. I hope you can hear me well.
Perfect.
So to answer your first half of the question on how pharma companies are adopting decentralized trials, I think tele-trials and telehealth have been in existence even before COVID, as all the other panelists have repeatedly mentioned. However, I find that definitely there's a shift in the industry mindset. I am not only hearing a lot of discussions about boosting recruitment through the implementation of tele-trials, but also about diversity in clinical trials. The mindset change is significant to the extent that when I receive a new protocol, I now consciously ask myself a question: can we deliver the study using the tele-trial model? In fact, BMS already has 2 studies where we have adopted the hybrid model, and a third study which is an extension study to collect survival follow-up data, where we're looking at implementing e-consent and telehealth and other aspects of the model. I would just say that adopting the teletrial model at the outset aids with quick startup process as compared to adoption of the model midway in a study when we start to see challenges with recruitment. Every panelist has touched upon this. We've seen massive disruption in enrollment at our sites due to COVID-19. And this leads to your second question of how I'm helping sites to support the implementation of the teletrial model. It's more about communication and collaboration. So I facilitate communications to understand site capabilities. And when we have these discussions, you tend to realize that some of our regional and rural sites have more capabilities than we know. and where there is a lack of capability, we can help to bridge them. We have worked and we are working with several champion sites like Keynes and Townsville in Queensland, and more recently with Alfred. And we've heard Cheryl Ann's story about how she set up the teletrial model for a sponsor between Alfred and the Royal Hobart Hospital. And this gives us great encouragement to proceed with the implementation of this model on our studies. And we're also seeing great interest from the investigators. We see a lot of emails come through asking if BMS would be able to collaborate with the site to set up a trial model on a particular study, which is great to see.
Fantastic.
There are variances though on how sites in each state are implementing the teletrial model. And I think Robert touched upon some of the topics or concerns that I have been having, and it's great to know that there are going to be standardized SOPs and other guidelines that are going to come through for the conduct of clinical trials, and that is going to aid not only the sites but also the sponsors, and especially the document that will delineate the responsibilities of the stakeholders. I think that is something that I look forward to. I think that the challenges, my time has mostly been spent in addressing challenges, and challenges are related to, like I mentioned earlier, the governance requirements varying between sites. There have been challenges with durable setup, for example, turnover of key staff. So my point of interest would be to see how the sites help with passing on the knowledge to other team members for us to continually implement the teletrial model without having to take a break or having to go back and dig for information, because that's
really making it business as usual, really making this part of just about every single trial that we roll out, that there is an element of decentralisation embedded in the design.
Yes.
So we're not constantly relearning. We're learning as we go, but not relearning.
Right. And also my role has been in bridging knowledge gaps. So I have worked with sites like Keynes and Townsville, and I usually take what has worked with those sites and share it with other sites to see if that could help them improve their processes, their SOPs. I've also been connecting sites and for implementation of maybe a single EMR for the primary and satellite sites could work in some states, wouldn't work in some states, but still I'm happy to share those kind of learnings with other sites, and I've been doing that as well. Also, a lot of time is spent in reviewing the supervision plan and providing the feedback. Supervision plans can sometimes be poorly or inadequately written. So directing the site to the correct information, to ask questions about whether they are capable of implementing items that are listed within the supervision plan. For example, teleconsenting. Does the site have the capability of implementing teleconsenting? Has the ICF been approved or has been adapted to include details regarding teleconsenting for patients? If those aspects have not been included, then it would not be a good choice to make and implement on a study. Questions like who will report SAEs at a telesite? Can the telesite unblind patients? Yes, of course they can, but do the telesites know that they have that capability? Also, we touched upon central pharmacies. As a sponsor, I think about how drug can be shipped to the primary and telesites. Within BMS, we have lack of capabilities to simultaneously ship drugs to 2 locations. But we have tried and involved third-party pharmacies to whom we ship drugs, and then they reconstitute the drugs and ship it to the primary and tele sites based on the patient visits. So we have tried to work around difficult situations, and it's worked out pretty well for us. Also about thinking about very minute things like, can central labs ship directly to, can central labs ship lab kits directly to the primary and tele sites? And such thoughts basically reduce this one extra step that the sites need to take, and basically reduce the time between patient screening and enrollment, treatment on the study. Also, we look at building cost efficiencies where possible. For example, monitors reviewing data for the teletrial patients sitting at the primary site can be done.
That's a really important question, isn't it, Ramya, around efficiencies? And we're going to, I'm really sorry to cut you off, but we are over time. But if anybody in the audience wants to know any more information from any of our panelists, then you can certainly reach out to us at Praxis, and we will be happy to put you in touch. So it's just info@praxisaustralia.com.au. And we're happy to send you or put you in touch with any of the panelists today. But and I know that people are dropping off, and that's fine. But if there's others that want to stay, I just wanted to take this last question to the panel as a whole. So, and Natalia, I'd really love to hear your thoughts here as well. So, describe your perfect vision for clinical trials in Australia, and Maya, we've put other regions in there as well so that you can contribute. But what should the future look like? Who'd like to go first?
Well, if you don't mind, I would like to maybe mention my dream. When I started Firmicure, I started it because my sister was sick, and I was looking for a clinical trial for her, and I found one, but it was so away basically. So in the perfect world, I would imagine that a clinical trial will be no matter where you are, and you would be able to participate. And let's say in the ideal world, your physician can become the investigator as well.
Love it. And that's really the teletrials model. Others?
Oh, mine's very simple, Melanie. It should become business as usual.
Fantastic.
Yeah, but I just want to reiterate what Roberta said. Hopefully, in the not too distant future, especially with the implementation of the national framework, that it will become like the NMA, so business as usual. Yeah.
Natalia?
I agree with Roberta and Maya, and I also, in the ideal world, would see that your doctor would be able to actually know what all the trials are that are available just in one place, and be able to look them up.
Wonderful, wonderful. Does anybody else have anything they want to contribute?
I would agree as well. I mean, ultimately, it's about the protection and welfare of participants. So what's going to work for them? There's obviously the will there, there's the resources, the plans. So it's just a matter of putting it all together and making it happen in the context of the site and in the context of the study. You know, you talked about the risks. So there's going to be variations, but it sounds like, you know, there is the will and the ability and the capability there to do it.
Yeah.
Well said, Trina.
Australia is such a quality place to perform clinical research and clinical trials, and caring for the patient has never been more important, and putting the patient at the centre of everything is so important. We can do it in Australia. Let's do it. Let's lead the way. Let's show the world. And
that is exactly why I wanted all of you here today, because you really highlight the capabilities that we have as a nation. And we should be working. I mean, one of the greatest things we've seen as a result of COVID is this sense of collaboration. And hopefully now, with a bit more exposure and building that awareness, we can be even more collaborative and make this a reality. And as Roberta said, and gave me the title for the session, business as usual. So I'd like to thank you all. The Q&As have been largely answered. I may come back to the panelists to get some specific questions and answers to take back to those that have asked questions where it's relevant. But I'd like to thank all of our audience for being here today. A special thanks to our panelists, a special thanks to Natalia and Maya. I don't know what time it is where you are, Maya. What time is it?
really late in the evening. So just enjoy your day.
You go and have a good sleep. Thank you all. Have a great Monday and a great start to your
Stay
week.
safe. Bye-bye.
And we really appreciate you all joining us.
Bye.
Thank you,
Bye-bye, everyone.
Bye.